Right. So good morning or good afternoon, everyone, and thank you for joining us for the latest webinar hosted by the Better Breathing Institute. Today's webinar has sparked a lot of interest. We have nearly had 250 people register, and I'm pleased to introduce Dr. Francesco Ferraro onto the platform, who will be discussing whether respiratory muscle training improves balance and to what extent. Dr. Ferraro is a lecturer in sports therapy and rehabilitation at the University of Derby. He has a wealth of experience from working in the UK, Italy, and Pakistan, and he has collaborated on international research projects with the focus of his research being the fields of physiology and biomechanics. Dr. Ferraro is interested in how we can improve functional mobility and overall well-being through the incorporation of health and technology. He has extensively studied the role of the respiratory muscles in enhancing health and functional performance. And today he is going to talk to us about the effects of inspiratory muscle training on balance and mobility in older adults. The pioneering research undertaken by Dr. Ferraro in this area has provided insights to design evidence-based interventions in rehabilitation and athletic performance. It is safe to say that he is well positioned to deliver today's talk, and without further ado, I will hand over to Dr. Ferraro. There will be an opportunity for questions at the end of the webinar, so please do write in the chat as we go along.
Thank you very much, Sabrina, for having me here today, and thank you for all the people that are joining us on this seminar. So as Sabrina mentioned, well, I'm not going to introduce myself again, but just to give you an overview of kind of where this idea came from and why we are here discussing the relationship between inspiratory muscles and balance. I have to give you a bit of information about my study background and where I started. So I started with a bachelor in sport and exercise science at the University of Rome for Italico in Italy, as you can probably guess from my accent and my name. I then did a master in sport exercise science for prevention and wellness, which is kind of similar to something that in the UK we call sport therapy. And after that, I did a PhD in physiology and biomechanics, focusing on the role of the inspiratory muscles. After that, I also completed a master degree in, well, I'm completing a master degree in computer science at the University of Liverpool, focusing on artificial intelligence. And I've done a master degree as well at the University of Venice, focusing on project management. So I have quite a different kind of broad of experience in terms of studying. Following kind of the PhD, I also work with the Orthopedic Research Institute, and I know some of my ex-colleagues are going to be on this call as well to see kind of how things have progressed. But during the time at the Orthopedic Research Institute, we focus especially and particularly on hip replacement, which actually links and will link at the end of this presentation with inspiratory muscle, but I'm not going to spoil it for now. So let's kind of give you a bit of an overview and background of kind of who I am and why I'm here talking to you about those things. Now, the journey that I'm going to explain to you and I'm going to guide you through basically is focused on one specific research question, which is how can we help older adults improve their balance and become more independent? And you will see that this research is what is called a patient-centered approach. So we're going to use information, not just data from a quantitative point of view, so not just information about balance and mobility and inspiratory muscle strength, but we'll also have additional information about perception of the training, how people experience the whole research process. But without further ado, let's have a look at the slides and the material I organized for you. Now, the first thing we have to do in order to talk about this topic is to provide a clear definition of balance. And that's not something quite simple. If you read around different research on this topic, you will find that there are lots of different definitions. And from a research perspective, we must clarify what we define for balance. And how it's different from other terms, such as stability, such as dynamic balance, reactive balance. So there are going to be different types. But we have to provide a clear definition to make sure that on kind of this hour that we have together, we talk about specifically balance and we give a clear definition. Now, when I have to do that, I always use these slides to terrify my audience because this is a biomechanical point of view of what balance actually is. According to a paper of Barton 2016, where balance is actually defined with a mathematical perspective using the different joints as a point of orientation. But that kind of makes a very complex biomechanical explanation of balance, which really doesn't help our case. But just to give you an idea of, before we start, how complex balance actually is. Instead, the way of I normally use to explain it is with the aid of Philippe Petit, who walk around. I don't know if I pronounced the name correctly. I apologize. My French must be terrible. But I use this example as someone who walked between the Trade Center in 1974 without any aid at all. Now, how did he do it and how we can actually explain that when we talk about balance? Because he must have an excellent balance in order to do that, isn't it? So he was able to complete this task without any aid or any support. So in order to define balance and to kind of help me with this definition, what I do, I go back explaining and try to explain it using the Newton laws. Kind of, we all know, and we probably are on your desk right now, or anyway, in a place where you can actually observe this phenomena quite easily. If you have something like a box, or like in the case I have next to me, a series of tea mugs on my right, what happens is that objects normally don't move unless you put some forces to it. And they don't move because the amount of forces acting on a body or on an object in this case is going to be equal to zero. Because you have a force pushing down based on the mass of the object multiplied for the force of gravity, and there is an opposite force in the opposite direction, so that the total amount of forces is going to be equal to zero. Okay, fair enough. This is kind of basic physics. And when we work around that idea, we can have three types of balance. So we can say balance is when the total amount of force acting on a body is equal to zero for now. And we can have three different types. We can have what is called an indifferent balance, which is the one with this marble here, where the object will remain in that position. And if I apply a little force on one of the two sides, it will simply roll to the left and to the right until there is another force stopping the object to move. We have also what is called a stable balance. So if I apply a force to the object to the right or to the left, it will change position until it will gain back the same starting position where it is now. And then we have what is called then a stable balance, where if I apply any forces to the left and to the right, the object will move far away from the starting position. You can say, Francesco, this works very well with small object or box or mugs, but how does it work with human body? Because certainly we are not marbles, isn't it? It's a bit more complex than that. And you will be right in saying that, because actually when we talk about balance in terms of human balance, we have to include additional concept to make it clear and define what actually balance is. We need to include the concept of central gravity, which is kind of an hypothetical or kind of virtual point around which all the forces of your body act upon. And that specific point is around your hip joint. And some authors say that it's about 2 fingers above your belly button or around your belly button. And this kind of is the point where the amount of forces, the amount of, well, forces is not probably the correct term, but say the amount of mass of your body it is. And the projection of this point, of this specific little point, which is the center of gravity, the projection to the ground is called the center of gravity. So this is called the center of mass, and this projection is called the center of gravity. But the center of gravity falls between your feet, and this space around this area that we design with our feet actually has a specific name. That's called the base of support. And as you change the base of support, so as you change the stance of your feet, Of course, you are changing the area between which the center of gravity falls. And shorter, smaller is the space, then harder will be to cope with balance. Indeed, I'm not asking to do that because normally I will do that in class so I can see who I have in front of me. So I'm here, it's difficult virtually, and please don't try this at home. I'm not going to take any responsibility for any fall. But if you try to stand up and try to change your stance, so the way you have your feet on the floor, and having wide as your hip or wide as your shoulder, of course, standing up, your balance will be pretty good. But if you try to use one of these other positions, and especially the last one, having one foot in front of another one, you will see that your balance will be less good and will probably start to sway a little bit to the left and to the right. If you try to do it with your eyes closed, it will be even harder. So going back to what we mentioned before we mentioned that to have a good balance, the total amount of forces must be equal 0. And we saw that there are different types of balance, isn't it? We talk about indifference, stable, and unstable. For human body, as we saw, we introduce additional concepts such as the center of gravity and the base of support. We can provide now better and clear definition of what actually balance is. And indeed, we talk about the what is called a stable balance. This is from Kibele, a paper of 2015. We have stable balance, metastable balance, and unstable. So now instead of having indifferent, stable, and unstable, we will have stable, metastable, and unstable. What it means is that we have what is called a stable state of balance when the projection of the center of mass, the center of gravity, falls within the base of support. And that's kind of quite easy to think about that, because that's kind of, you have 2 points of support, which are your feet. And if the center of gravity falls between them, you're absolutely fine. Now, things change if you're moving, because we are not static objects, so we tend to move around. And if you're running and changing quickly the base of support, still, if this projection of the center of mass, which is called the center of gravity, is in within the base of support, you are in a state of meta stable balance. So you're moving around, the projection is still in within your area, even if your area changes quickly. But you will use your balance, and that's kind of quite important to understand, that you will use your balance the moment your your center of gravity falls far off the base of support. So that's when we experience a fall accident. So to go back to Philippe Petit in 1974, we can make this story extremely simple, say, well, he was able to perform this task and to walk between the trade center simply because the center of mass, the projection of the center of mass or the center of gravity was falling in between the base of support. And as long as he was able to hold that, well, he was able to walk between the two towers. Now, you can argue that that's a very simplistic explanation of it. Well, I know we have only an hour, but there is also something else to add to this story, because again, we are looking from a biomechanical point of view, and we are totally kind of not considering elements of physiology and elements in relation to our muscle and our brain. Yeah, you're right. We need to mention those things as well. Because we see that there are differences if I keep my eyes closed, if I have my eyes open. So there are other things that can affect balance apart from the center of gravity being within the base of support. So to do that, now I'm going to ask to Simon Biles to help me out. So when we have to perform a task, a complex task like this one, our brain does something that is called, we can call it as a proactive balance. So the athlete, or the person in this case, is thinking about the action that she has to do. The brain processes this action and then perform the task. That's called proactive balance. Very simple. I mean, in this case, it's complex, but when you have to think about the action, you actually don't think consciously at it, but your brain does it for you and organize your body so that you can perform it properly. Although things might happen, and what your brain does when things change quickly and your center of gravity is falling far off the base of support, well, your brain reacts and therefore when something like that happens, we talk about reactive balance response, right? So we have a proactive when the brain knows exactly what to do and perform the task properly, and reactive when something shouldn't happen and we have to respond to it quickly. Now, when we age, or if we have any specific impairments that can affect balance, what happens is that the specific elements of reactive balance tends to decrease, and we are not able to cope against unbalanced situation or unstable situation, to use the words used in previous paper. We are not able to cope against it quickly enough, and therefore we have a fall. So this introduced kind of the physiological mechanism behind balance, and now we can actually provide a clear definition of it. So if we look at what I mentioned before in terms of biomechanics point of view, and now we combine the physiological element, we know that from the physiological point of view, there are 4 elements that help you to have your balance. And those 4 are the musculoskeletal components, which basically are your muscles. The somatosensatory system, which is basically how the brain sees your body and how you perceive the environment around you. So that's why there is the cortical homunculus there on top. The vestibular system, which is the one that is connected with the cerebellum, but generally speaking, we simply say that is the one in your ears, but it actually is a bit more complex. But for simplicity, we say that is the one in your ears. And what it does, it gives information about acceleration. Indeed, you don't feel the velocity of your car, but you definitely feel when you hit the brake, because you can perceive the variation of velocity, which is acceleration, but you cannot perceive velocity itself. And then we have the visual system, which is the information that our brain processes throughout our eyes and gives information about the environment. So giving all this pot of information that I try to give you in about only 20 minutes, we have now a clear definition of balance. According to Pollock, 2000, balance is a multi-dimensional concept referring to the personal abilities or someone's ability not to fall. So you will have good balance simply if you don't fall. And that's kind of a simplistic, but I believe brilliant explanation of it, because if we have to touch upon each of the topics in terms of biomechanics or physiological component, it becomes extremely complex, but we can narrow down to the ability of a person not to fall. So that's balance, ability of a person not to fall. Now, the question you might ask me is, okay, Francesco, we got balance is the ability of a person not to fall. Fair enough. But how do we actually improve balance? Well, balance is not like something fixed. As for anything, almost everything in your body, it's something that you can train. And if I go back to the slides, clearly you cannot actually do much yourself in terms of training with those capacity here, those skills here, but you can definitely improve your musculoskeletal components. You can improve the strength of your muscle, isn't it? That's kind of the main thing you can act upon. And therefore, over the course of years, many authors come up with different ideas or different type of techniques. The picture that you see here, this is sit-to-stand exercise, are part of what is called the Otago, like the university and the city in Australia, the Otago Exercise Programme, which is kind of the gold standard in terms of balance exercises. But the Otago Exercise Programme, or any other program that follows from that, such as the one reported here, they use variable resistance training or standard resistance training like weightlifting, they do focus on strengthening the abdominal muscle, the core muscle, let's say, as also the paraspinal one, abdominal one, and they focus on increasing the strength of your lower limbs. That's kind of the main approach when it comes to balance exercises. Some of you might have been to classes of improving balance, and you definitely have noticed that the majority of the focus, the majority of the stress is always on the lower limbs, because we know it works and it's actually easy to train. So the question then arises, I mean, what is the role of the diaphragm? And if we are here talking about it, there must be something that I haven't told you yet. So the diaphragm must play a role, but what this role is going to be, and actually, if we focus on lower limb and it works, what is the point of looking at the diaphragm as well? Let me explain. Let me get into that with a bit more details. So I assume, but I'll go through it again, just for clarity. I assume that if you are here, you probably are familiar with the respiratory muscles, and you know there is expiratory and inspiratory muscles. Now, this picture is from a book of McConnell, 2013, and we don't have to go in detail of anatomy, don't worry, but at least we have to know that the main muscle of inspiration, so when you breathe in, is called the diaphragm, has this very peculiar structure that you can see here, because it's a dome-shaped muscle that has attachments as well, not only to kind of the rib cage, but also down to your lower portion of your spine. So this muscle is the main muscle of inspiration. So every time you breathe in, you are using the diaphragm. Now, what happened with age, though, is that this structure, these components do change with age. And that's kind of one of the many things that, unfortunately, from a physiological point of view, from a physiology point of view, they tend to decrease in terms of pulmonary mechanics, lung function, locomotor emphysis, respiratory muscle function, and etc. So what happened is something that many authors, including Jensen at the early 2000s, has defined as senile emphysema. So it's basically a decline in your overall breathing system, also affecting the structure of the diaphragm. So we know that, so to summarize and to kind of help you following the route or path that I'm going to, what we know so far is that age has a decline in terms of breathing capacity and the structure of the muscle that are around the breathing system, including the diaphragm. Now, up to this point, though, we still don't see the link between diaphragm muscle and balance, do we? We haven't mentioned that. And to mention that, and to get into that point, we need to go back to actually the latest 90s. And I'm going back to 1997. It's a bit of a history journey, I mean, between Philippe Petit in 1974 and now in 1997. Now, in 1997, in Australia, there are two researchers. They are called Hodge and Gandavia. Now, they come up with this idea. They thought, wait a minute, I want to see what happened to the diaphragm when I actually move all the limbs. And in particular, I want to see the contraction of the diaphragm as when the shoulders move up and down. So what they did, they stick a needle with an EMG, so something that can detect the contraction of a muscle, to the diaphragm of the participant. As you can see here, this is from actually their paper of 1997. So they wanted to see how the muscle, and if the muscle contracts and has any effect on any kind of movement or action, contraction, when someone performs some other movement, they are not in relation to breathing. So what they did, they create these charts. This is from their paper of 2000. And as you can see here, I'll help you to kind of navigate this figure. We have the shoulder movement, which is this one here, with particular attention to the anterior deltoid and posterior deltoid. And what they notice is that when the shoulder moves, and this line here, this black line on top, are the muscle contraction, they also monitor the contraction of the diaphragm. Now, when the shoulder is not moving, we have kind of a standard patterns, which is clearly someone breathing. But when their participants, and I think they had around, I didn't have many, but they have around 15 participants, if I remember on top of my head. But when the shoulder was moving, they also record a different type of contraction of the diaphragm, as you can see here. So this is definitely different from the one that we had before the movement. And actually it's different from the one as well that we have after the movement up here. So the diaphragm is contracting, is co-contracting when we have movement of the shoulder. That's something quite new. That's something that, again, we are early 2000, 1997, 2000. It's something that no one has ever seen before. It's the first time we're looking at it. Now, this can only mean that the diaphragm must play a role or does something anyway to keep the spine in line or keep our balance. We don't know. We have to investigate in more details. What we know for a fact, though, is that the diaphragm is the roof of our core muscles. Now, core muscles is a term that we can use, although it's no ideal to use the term core muscle. It's very used and very common when we talk about sport and exercise, but it's not as well common when you actually look into the med research of clinical research, because it's actually it's a structure made by a group of different muscles. And it looks like, as you can see in this picture here, it looks like a cylinder, but on top and at the bottom of this cylinder, so up here and down here, we will have two diaphragms. One is going to be the breathing one, the one I'm talking about, the one that Hodges and Gandavia measured the contraction of. And the other one at the bottom is called the pelvic diaphragm. So the diaphragm is definitely part of this cylinder. And we know that the core is extremely important for your balance. And that's not something that Hodges and Gandavia reported. It's something that is extremely well known and extremely well reported by many other authors all the time. Now, if this is true, so that these core muscles, including the diaphragm, are important to cope with balance, and if we know that the diaphragm contracts when there is a sudden movement of the shoulders, we can probably look at what happens if we train the diaphragm and then we measure balance outcome. Will the diaphragm have an improvement? And this improvement in terms of strength, this improvement translates into improvement in balance. Thank God we have a way to train the diaphragm so we can actually do that. And a way of doing it is using inspiratory muscle training. So here, as you can see in this video, this is an example of how to use the power breath and how every time we have a contraction, it really works as a dumbbell before your diaphragm. And as for any type of other training, we know that these type of exercises follows the overload principle and the specific principle. Overload principle means that we can change, we can tolerate duration, intensity, and frequency. And the specific principle is that if we want to increase strength, we will gain strength. And if we want to train endurance, we will gain endurance. The question then arises, well, Francesco, that's brilliant. So we know we can train the diaphragm, and we know that the diaphragm might help in balance overall, although we haven't seen how yet. But since it's the top, or anyway, the roof of the core muscle, it might have some effect in coping with balance, as reported by Hodges and Gandavia. But you can ask me, well, that's brilliant, but does it really work? I mean, we know roughly what power breath is and now inspiratory muscle training is. And if you are here, you probably have one already, or you are very familiar with it. But still, you might wonder if it really works or not. Thank God we have quite few papers, and I think now it's 3 decades of research on inspiratory muscles, and has been used with many different type of cohorts. And I'm referring in these slides in particularly from a sport perspective, so like trained cyclists, sprinters, rowers, runners, but also with patients such as COPD patients. So we have a very solid and a strong background of using the inspiratory muscle training to improve breathing capacity, in particular maximal inspiratory strength and the overall strength of the breathing muscle. So we can definitely use it to train the respiratory muscle, in particular the inspiratory muscles. So let's see then now. Okay, so we can use IMT to improve inspiratory muscle strength and therefore potentially balance. We don't know that yet, as I haven't shown you that yet. Now, another question you might have for me is, well, Francesco, that's brilliant, but, you know, there are other type of intervention. You mentioned that, you know, variable resistance training, focusing on the lower limbs, focusing on the abdominal muscle, killing ourselves with lots of crunches. But why do we need to kind of look into that? Why is research on fall prevention, or anyway balance, which we mentioned is the ability of a person not to fall, why is that important at the end of the day? Well, according to the last kind of figure, we know that 30% of people are high risk of falling between 65 and 80 and 70 years old. And that increases to 50% of people being a higher risk when they reach 80 years old. With a cost, and I'm talking about NHS only, so I'm talking only nationally in the UK because it's where I'm based, with a cost of about 2.3 billion pounds per year. And is one of the leading causes of death for people over 75. So, I mean, that kind of shows how important it is to actually research on balance. And I'm glad to know that we are here in over 200 people are anyway registered for this seminar, which means that it's a topic that we are looking into it, and we are looking into it together. So people are interested about it. And that's extremely, extremely important. Also because according to the NIH, we know that the life expectancy is expected to increase by 8 years now, which basically means that we are expecting to have almost double the people that we have now. They're going to be in the 80s. So a higher chance or have a bigger cost and higher life-threatening accident due to fall and lack of balance. Therefore, doing research on this topic is extremely important now, because we know how numbers are progressing and we know how the population is actually progressing. So going back at the very first slide I showed you, we now need to look at kind of how can we help older adults improve their balance and become more independent. And I'm now going to look into the specific studies that help us out to actually understand the connection between diaphragm and balance. So in order to do that, and that's something I think we have done in the past 10 years, if I remember correctly on top of my head, we have to find a way to actually understand this relationship. And we have to find a way whether or not to see if inspiratory muscle can help in improving balance, and actually if we can use inspiratory muscle training to improve balance. So the first thing we did at the time, I think this research is 2017, we ran the gold standard of clinical trials, which is the random control trial. And we did it as a randomized double blind. And at that time, I was working with Professor Gavin, Professor Wainwright, and Professor McConnell. So we come up with this idea. Say, okay, well, we have to prove it, that actually, potentially, if we improve inspiratory muscle strength, we might have some results in balance. So what did we do? We created this specific trial in which we had two groups of people involved. We select only people that were above 65 years old with no specific condition, so something that is called healthy older adults in kind of research jargon, research terminology. And we'd split them into two groups. One performing to inspiratory muscle training for 8 consecutive weeks, and the other groups performing a placebo intervention, or as we call it in kind of sports science terminology, what is called a sham intervention, in this case, sham MT. With sham MT, we mention a type of intervention that actually used the same device, which in this case was the power breath, but without any resistance inside. So people were training their breathing, but without any resistance to it. And if you are familiar with the power breath, you know that you must have the spring in it, and you must increase the load if you actually want to have some results in terms of inspiratory muscle strength. And we test them before and after. So at the beginning, what is called baseline, so week 0, and then after 8 weeks of training. The results were quite promising. We ran a battery of different tests, and I'm not going to spend time going into each one of these tests, but I will focus only on some of the balance results. For balance, we used what is called the mini best test. Now, the mini best test is a test that measures balance. Then basically you give points up to 28 on different areas of balance ability, including anticipatory, which are things such as standing on one leg or standing on the tip of your feet. or we have something that is called reactive balance that asks for the reactive principle I showed you before with mobiles. You ask someone to have the center of gravity far away from the base of support. So you basically make someone fall and see how quickly they react to their falls. Of course, you catch them if they are falling. You're not going to make them fall. Then we have what is called the sensory. So you ask people to perform simple tasks with their eyes closed. And then dynamic, which basically are things such as gait ability. So how people walk with head turns, how people walk stepping over obstacles. And we test the IMT group, which is this one here, versus the sham IMT group, which is this other here. As you can see, we had an improvement from 20 to 24 in terms of balance. Willis, the improvement in the sham MT was just from 20.8 to 21.3. So what is called the between group differences. So when we run statistical analysis, we need to look at differences between groups. So we noticed that actually the IMT group improved and have a change of about 18.1% compared to the sham MT, which only had an improvement of 2.4. So this was our first finding. So with this study, we noticed two things. First of all, using inspiratory muscle training for 8 weeks improves balance. And second of all, it was feasible. It was feasible to use with people over 65. And that's not something to take for granted, because when you give a device to someone and say, you know what, I want you to exercise for 8 weeks, I'll see you after that, without any calls, because it was double blind, so we couldn't actually contact them, without any reminder. What we gave to them was a training diary. And in order to make sure that they actually perform it properly, we had what is called the MIP measurements. The MIP measurement is the machine of truth, because it measures the strength of your diaphragm, or anyway, your inspiratory muscles. And if you haven't trained, that will never change. So that's kind of the way we tested that they were actually performing the exercise properly. So this study shows the feasibility, but it also shows that by training your respiratory muscles, you have improvement in balance. But it wasn't enough, because we need to actually check whether or not this improvement on balance, how good are they when we compare with the gold standard? And if you remember what I mentioned before, I mentioned that the gold standard is called Otago Exercise Training, and was the slide with the sit to stand. So we say, okay, we can do that. Same research team, myself, Professor Gavin, Professor Wainwright, and Professor McConnell, we designed this study in which we had two groups. In this case, we have a group performing IMT, so inspiratory muscle training, and a group performing Otago Exercise Programme without any IMT. So we were comparing IMT versus the gold standard. How did it go? Well, we had, again, another battery of tests. I'm not going to get into the details of that, but we actually noticed that, as expected, both groups had improvement in balance, right? So the IMT went to 19 to 24, and the Otago Exercise Programme went to 14 to 19. So they both had improvement. But, and indeed, there was no differences between group, but actually only one type of balance in within the mini best changed, and that was dynamic. So dynamic in the IMT had a massive improvement compared to the Otago Exercise Programme, being significant. So this study actually was extremely interesting, because it shows two things. First of all, is that IMT is as equal as effective as our Otago Exercise Programme, which is the gold standard. And remember, the IMT is only targeting the diaphragm. It's not targeting the lower limbs. So we are saying that just stressing the diaphragm has the same results than stressing the lower limbs. And we know that exercising with the power breath is actually easier and safer, because you can do the exercise sitting at home in your chair or your sofa, or even lying in bed. Indeed, is very common using clinical practice in that setting. So with patients exercising in their bed. And also, something that we notice is that the improvement in dynamic balance were higher in the IMT group compared to the Otago Exercise Programme. Now, that's something that is extremely interesting, and we can find out more about it in the following studies, because we said, okay, that's very good. So we prove it that it's feasible with the first study. We prove that actually training the inspiratory muscle does result in improvement in balance. And we notice that actually respiratory muscle is as equal as good as Otago, although it's probably better when it comes to dynamic part of balance, such as I mentioned before, things such as gait analysis, so such as walking with head turns, walking and stepping over obstacles. But that's not enough. Of course, we need to get into more details. We need to understand actually how it works. So we said, wait a minute, we can do what is called a pool data analysis, or some other researcher can call it as a sort of a meta-analysis. So same research team, myself, Professor Gavin, Professor Wainwright, and Professor McConnell, we developed a study that was looking at a massive amount of participants, collecting information for all different studies. The two that I showed you before, plus other one that we also carried out before that as a sort of pilot. And we combine all those data together. And what we did, we actually looked at things such as correlation, but also specific clusters. And we noticed that the biggest and the highest improvement were in people that were older, so between 76 and 80 plus. I remember we even had participants that were around 98 years old. So they are the ones that have the highest improvement when they exercise their respiratory muscles. And we also noticed that MIP, so the one that I mentioned, the machine of truth, the maximal inspiratory pressure index, actually correlates with the mini best, which is the test of balance, has a positive correlation between the two. So improvement or stronger MIP are translated in better balance. Release lower MIP, lower inspiratory muscle strength are equal to lower balance. That's also very interesting because it shows the clear relationship between those two, or at least the correlation between the two. So here's kind of some of the funding that I just mentioned, summarized from the research paper that I mentioned to you. But is that enough? Of course, it's not enough. We have to dive deeper in order to understand the relationship between the diaphragm and balance, the respiratory muscles and balance. Therefore, we run what is called an kind of analysis of the equation that allow us to predict MIP. And we look this relationship, especially for older adults, and trying to see whether or not those existing equations that have already been published can help us out to see this relationship. And in this study, we noticed that actually the current state of art when it comes to predicting the maximal inspiratory pressure and therefore potentially the balance of our patient or balance of our participant actually underestimates the power of, anyway, the strength of the respiratory muscle. So we published this paper quite recently in collaboration with our researcher from Valencia, Noah Roldal, and Professor McFaggy from the University of Derby. And we noticed this relationship, which actually was quite interesting and helped in develop future research. They are now under developing, and I cannot mention those yet because they are in the process of being published. But anyway, we are still looking into that and still trying to understand this relationship. However, there is a big gap in this, all this research that I mentioned. There's a huge, massive gap. And I hope you notice that, because so far, the only thing I've done was quantitative research, isn't it? So I'm just reporting numbers. I'm not mentioning nothing else about our patients. So yes, something is missing, and there is a huge gap in terms of research here. So our research question initially was, how can we help older adults improve their balance and become more independent? And I mentioned it was a patient-centered approach, but so far, there's been not of patient-centered approach. Plus, we have improved their balance for sure, but have we actually helped them to be more independent? So yes, we have improvement in balance, in mobility. They become more independent. They have a lower risk of falling. But I mean, there was a lack of engagement overall and loneliness. And still, our intervention, as for the Otago, any other one that use variable resistance training of weight, is very prescriptive, and there is no social interaction. So yeah, we're improving balance, but we are basically we are making our we are making our participant exercising without extremely prescriptive intervention. We're not helping in becoming more independent in a way of developing social skills and also participates with others. Because, you know, the power bit, you just give it to the device, or any, I say the power bit, but any respiratory device, you give it to the people that exercise and you ask them to come back in 8 weeks. So there is this huge lack of interaction and engagement. So we say, wait a minute, we can do something in there. So we must bring social interaction in our research. We must work not just from a quantitative point of view, but from a qualitative point of view. So we developed 2 research, and we are now working on another one, which is on its way. So we decided to combine IMT with Tai Chi. So in this case was myself, Dr. Yutao Zhu from the University of Hunan, China, Dr. Ainhoa Roldao from Valencia, and Dr. Rania Edris from the University of Derby. And we create a multidimensional respiratory muscle training and Tai Chi intervention. And we had 2 papers out of this research. One was kind of a combination of the intervention that it was similar to the first study I showed you, in which we had an experimental group performing IMT plus Tai Chi, and another group performing IMT plus, sorry, shame IMT plus Tai Chi. So it was again a sort of a placebo IMT, but they will still training with Tai Chi. And we looked at differences and improvements, and as expected, the people that performed, that's mini best, the people that performed the IMT plus Tai Chi had a better improvement in balance, so from 22 to 25, compared to the participant who actually performed Tai Chi plus placebo IMT or shame IMT. We actually had a decrease in the balance with a significant differences between the 2 groups. And the second aspect of it, so there was kind of still the quantitative element. The second aspect of it is that we also perform interviews with our participants. So we had what is called a reflexive thematic analysis. So basically, we ask people, we have an external researcher, of course, because it would be a huge bias if I gave to them the power bit and then I asked them, oh, well, how was it? So we had an external researcher asking specific questions, and some of the results, and you can go and check on the paper for more information, but some of the results of the outcome were brilliant. So people were extremely happy of the social element of it. They were happy that other people were actually doing the same type of exercise, and they loved the social aspects of it. So the results are, in my opinion, are even more genuine to the one that we had in previous studies, because we actually had patient participant feedback on the overall structure of the research, because you can come up with an excellent idea to improve balance or any other element of health, but then if people don't like it, then what is the point? And that's why it's always important to have this sort of a mixed method. And we're now in the process of creating and publishing, actually we're in the process of publishing another research that we have done, in which we combine an IMT with another type of social interaction intervention, but I'm not going to spoil it now because it's still in press at the moment, so it should be out quite soon. Now, to get to the conclusion of this story, because I'm also conscious of the time, what does the future hold in terms of what I'm going to do next on the inspiratory muscles and relationship between inspiratory muscles and balance? Well, there are few research that are going on at this stage with our brilliant research team that I will mention in a moment. But something that we are looking at now, and we have published this paper with Dr. Rania and Professor Wainwright from the University of Bournemouth and the Orthopedic Research Institute. We actually looked at the role that the inspiratory muscle training can have in orthopedic, and in particular in what is called enhanced recovery after surgery. So we are thinking, now that we know that it works with healthy, because remember that all participants, I mentioned in all the previous study, they were healthy older adults above 65 with no specific condition. So now we can say, okay, we can explore that in orthopedics. So people that are going through hip replacement. So what we want to do is to decrease the length of stay and make sure that they recover quicker and faster, because we know that training the respiratory muscle improves balance. And to conclude, I want to thank all the collaborators that have helped across these and other research that are going on at the moment. I mentioned a few of the professors I work at the beginning, but here I'm mentioning the one that I'm currently working with, and some study already have Dr. Rania Edris from the University of Derby, with whom we're looking at these orthopedic elements plus the combination between different interventions such as IMT and Tai Chi. Dr. Ainhoa Roldan from the University of Valencia, who is looking at the application of IMT with other type of physical intervention. Dr. Shuman Serad from Pakistan, University of Islamabad, who has done lots of research on the application of IMT with diabetic population and how IMT can improve balance in the specific cohort. Dr. Yutao Zhu from the University of Wuhan, China, with whom we have done lots of research in terms of Tai Chi and IMT, including the two papers published. Professor Mark Fage, we probably already know from all his work that we are doing in terms of long COVID and the application of IMT with the specific cohort, and Professor Maria Luisa Iavarone from the University of Napoli, Partenope, with whom we are working on improve the patient-centered approach. And that's everything I think I've done right on time, Sabrina. And thank you so much for listening to me. And I'm open to any question that you have.
Thank you so much, Dr. Ferraro. That was honestly both so well presented. I was so intrigued and wanting to know what the next slide was going to tell me, and really fascinating. And I think, as you said and alluded to in one of your early slides, such an important topic, both from an aging population point of view, the impact on healthcare systems, thinking about cost, NHS resources, I'm talking specifically in the UK, beds. It sort of brought me back to my days when, as a junior doctor, I was working on the care of the elderly wards, and having multidisciplinary team meetings with physios and occupational therapists. And I do wonder if we were able to incorporate or set up IMT rehabilitation, if that perhaps would help people get out of hospital more quickly. And the figure that you said was 2.3 billion. Well, if we're looking at one power breathe device that costs £50 as an example, I mean, that is incomparable.
Yeah.
Anyway, I have some questions, but we did have a few that were sent in beforehand, and you've sort of really answered them. But one of them was talking about whether a person has to be exercising formally before they need, or in order to benefit from IMT as an intervention. And I think you've really answered that, but I just wanted to ask if you had anything else to say.
Yes. Should I stop the screening?
Yeah, you're
First?
welcome to. It says thank you. It's a very nice slide. But yeah, you can.
Should be yes. So you can see my face. So no, actually you don't have to have a certain level of fitness to start with IMT. The good thing about it is that it's one of those type of intervention or type of training that you can easily do at home. As I said, sitting down or even laying down. Probably what you want to make sure is that you are training at the right regime for you. So your goal is to get 30 breaths twice a day. And if you struggle with that, then you might need to decrease the resistance in the device by just simply twisting the spring inside it. Although if it feels too easy and you can achieve 30 breaths and probably 35, then you can increase it to at least 1 point on your breathing device. So I'll say there is no point of waiting to have a higher level of fitness or higher level of strength. You can start at any point and progress from there. But the most important thing, as for any type of training, is consistency. So try to use reminders. I think one of the main difficulties for lots of participants is to keep count, because you have to get to 30 breaths. But I know that now there are apps and specific Bluetooth device that you can attach to your breathing tool, so that will also help in counting. And I think that's where the future of respiratory muscle training is going to be, so that you will have a sort of a tracker in your cell phone, or now probably it links as well with Apple Watch. I don't know that in details, but you can see your progression and you have specific reminders. So yes, to answer the question, you can start at any time, really.
Brilliant. As you say, I think the future of any exercise, we're talking about respiratory muscle training, is how do we improve compliance, entice people to do their training? How do we monitor it? So I think all of these online platforms will come into their own. You've essentially answered a couple of other people's questions who were talking about protocols. You mentioned the 30 breaths twice a day. That's often what is recommended for people to start out. What obviously you've got a whole host of research. What devices do you often use for your participants?
So for our participant, we use the Power Breathe Med Plus. But generally speaking, it depends about the cohort that you have in front of you. Now, when we work with participants in research study, we call it clinical trials, and for kind of consistency, we tend to use the Med Plus, because it's also the one that is available at the NHS level. But for people who wants to exercise and trying higher resistance, I know that they can buy different type of devices, and I know that based on the color of those devices, I think there is the blue, the green, and the black one. They have different type of resistance, different type of thickness of the spring, let's say. So you don't have to use the Medic Plus unless I believe you have any specific conditions, such as people with COPD or people with asthma might prefer to use the Medical Plus, but otherwise you can choose any of the one available.
And obviously the Medic Plus has the lowest resistance level, starting at 3 centimeters of water, which is a real perk for people that potentially can't even lift that, which is why it's so brilliant. Somebody has asked, in the study that you looked at comparing IMT and the Otago exercises, was there a difference in the two cohorts of people used? She noticed that one were community residents and the others were care home residents. And does that have any impact on the results?
Yes. So what we did in that case, it was both were actually from care homes. So that study was carried out between Dorset and Somerset. And we target people in care homes also because we needed to make sure that we weren't able to carry on the Otago exercise classes without asking them to come to campus. So I remember the time I was driving my motorbike across the two kind of county, and bringing the device, carry on the analysis, and also supporting with the Otago classes. So there were both cohorts were from care homes. Of course, different care homes, but in terms of anthropometric differences, we test them before. There were no significant differences between the two groups. So in terms of age, height, weight, there were also breathing capacity, because what we do, we measure as well FVC and FEV1. So basically those are measurement of health of your lungs done with spirometers, and we check as well those, and there were no significant differences between the two.
Brilliant. So you can really compare the data. Somebody has asked how they can find your research articles because he would like to read them.
Yes, so I mean, I think there's going to be a recording, but all those paper are available if you can search them on Google Scholar, you can search them on PubMed and other search engine. Even Google has it. So you just have to kind of look for the keywords, such as you can use my name, and then you can have IMT. Random control trial or Otago, depending on which research you want to look at. But anyway, each of the title that I put it in the slides is actually the title of the research itself, is a screenshot from PubMed. So you can watch the recording back and select the study that you want. Just write the title down on Google, and it will be available for you. But if you have any question, you struggle to find it, you can always drop me an email, and I'm happy to share additional information if needed.
Thank you. I know I was avidly writing down a few papers I wanted to read and then thought I'll just go back through the slides.
Yes.
Somebody's written, this is an interesting question. Do you have any information on IMT and hypermobility or Ehlers-Danlos patients?
Sorry, say it again. I went cut off.
Do you have any information on inspiratory muscle training and people with hypermobility or Ehlers-Danlos? I think EDS is Ehlers-Danlos syndrome. I know it's Fiona, she works in Wales, and she says she sees quite a few patients with these conditions who present with breathing pattern disorder. And she's been using IMT to improve the diaphragm strength with the aim of reducing breathlessness, but they still have quite significant trunk instability in an upright position, leading to contraction of the abdominals.
Oh,
So any tips or evidence for working on balance to reduce breathlessness?
That's an
Quite an
excellent
interesting,
question.
yeah.
Yes, that's actually a very, very good question. So we haven't done research with a specific cohort. Now that I'm aware that there are many, I know that we are now developing in collaboration with some colleague in Turkey, some research that are gonna go in that direction. I believe it's something that is definitely coming up and is definitely will be available in the next couple of years. But at this stage, I don't think there is much in term of research in that area. But it's definitely an area that we need to investigate more. I agree.
Mm-hmm. One of the questions I had was the impact, or is there any quantifiable evidence to support the use of IMT if there is significant differences between the physiological parameters that you mentioned that obviously control balance. For example, if somebody has significant hearing loss, but they have very strong or good muscle strength, will IMT still impact their
Well,
balance?
what you have to think about is that from a kind of practical point of view, we cannot modify all the component of
Yeah.
balance that I showed before. So, for instance, how does it work with people that are blind? So you can improve the balance, but only to a certain extent, specific for the cohort. So I will say if they have people that have specific difficulties in one of the other fields that I mentioned before, yes, can be hearing loss, can be being blind. I assume they will improve their balance, but to a certain extent. Of course, we are not expecting them to improve their balance to the same extent you will have with someone that actually can have no issue with, like such as hypo vision or any issue such as kind of hear loss. So it's something that will improve, but in the specific cohort. So it will not improve as kind of to the same extent as we expect with people that are healthy. And that's something that we also see, let's say, in people with COPD. People with COPD, they know that they have a lower balance compared to healthy participants. The improvement in balance is evident. There are going to be studies there are studies on that point of how to improve balance and how IMT can improve balance in COPD cohort. But then making a comparison between the different cohorts, I don't know actually how I don't see much of the point of it, to be honest, because we are talking about different cohorts, so different people. You can make a sort of meta-analysis to see the extent to which IMT can improve balance, but that's more a mathematical game rather than research that has a real impact, in my opinion. Because it's like testing
Yeah.
apple and potato. So you might have similar results, but what is the actual point of doing that? So if I want to focus on improving balance for specific cohort, and maybe having a multi-component intervention that is not just using the IMT, such as the one that we did with Tai Chi. With Tai Chi, we used IMT plus another type of intervention. I think that's going to be the future, especially for specific cohort, like the one you mentioned, or like the one you mentioned before with hypermobility. I think we have to think a bit of not just one intervention for all, but we have to start thinking about tailored intervention for specific needs of the specific patient, and not just the specific condition, but the specific patient that we have in front of us. So sort of a tailored intervention. As we now speak a lot about tailored medicine, like done for the specific patients that you have in front of you. And similarly, we'll need to think about it in this way when it comes to training intervention. We cannot assume the 30 breath twice a day works for all. We have to find out which one is the best for the specific condition and specific person that you have in front of you. So to answer your question kind of in detail, we don't know. I don't have a full answer for it. My best advice is to start thinking in a way that says, okay, if this is the condition and those are the kind of index, the links with this condition, what type of IMT would be the best? Will 30 breath twice a day, which is the one that we have used for 30 decades, be the best option? Or shall we actually start looking into different type of IMT and combinations of maybe something like I don't know, supersets of IMT, or using different type of resistance across the different weeks. Or instead of working at 50% of MIP, why don't we work on 80% of MIP in a specific cohort? So we have to go outside the 30 breath twice a day. I think that's kind of that covers both questions, but the answer to it has not been published yet. So we can only make assumptions, but we don't have any evidence base to answer the question with certainty yet.
Yeah, thank you. There's just, if you've got time for two questions, one's quite short, one's very interesting, actually. They're all interesting. Somebody, Malachi, has said, thank you very much for your insightful presentation. He said, would people with asthma, are they more likely to suffer from balance issues later in life, or possibly in younger populations? And if so, could someone with mild or severe asthma train to improve and secure better stability and balance without exacerbating their current symptoms?
So what we know, we know two things for sure, is that people that have breathing condition that translate in lower level of balance, such as COPD, they had improvement by performing IMT. And we also know that IMT is secure to be used in patients that have asthma or COPD. So again, in this case, I will say yes, but using the IMT can definitely provide improvement in balance in patients that have asthma, because we have seen it with other breathing conditions. So it's fair to assume that we will have similar results. It kind of link again with what we mentioned before, isn't it? So it's like, if we're talking with patient with patient with asthma or asthmatic patients, using the power breath will definitely improve their balance because they will strengthen the diaphragm. And it links also with another aspect that I haven't mentioned in this presentation, because it's part of a lot of work that is going on behind the curtain. Because something that I haven't shown you yet is why we have improvement in balance. I show you that there is a link. I show you that there is a correlation. Actually, correlation is not equal causation. So why there is an improvement in balance? And that's, I think, as soon as we know that, we will answer all these questions. There are different options, different opinion on why we have those improvements. But it's not clear yet why stronger diaphragm is equal better balance. But we know that it is. So I'll say, to answer in short and briefly this question, yes, you can train with the power breath following the specific kind of guidelines for people with asthma without any issue, because I've been tested a lot on the specific cohort, and it will give improvement in balance, because that's what we have noticed in many studies now, that strengthening the diaphragm improves balance.
I look forward to your webinar next year then, when you can present the update.
Who knows where I'm gonna be next year? We'll see.
And somebody is, I was going to finish with this question. Somebody has asked if the mini best test is in clinical practice the best assessment of monitoring balance, or if there is a better outcome measure.
Now, we have different options here. We have the Berg test, we have the Tinetti test, we have the mini best test. Now, they're all valid. They're all being used in clinical practice. You can even use all the machinery that detect balance. Now, the reason why the mini best, in my opinion, is the best for these studies, but in general for clinical practice, because the mini best allows to see different components of balance. If you look at the slides that I mentioned before, we have what is called anticipatory, sensorial, reactive, and dynamic balance. So we have 4 themes of balance within the mini best. So that's extremely important because it allows me to see where the improvement was. If I have only one index for balance in general, I might not be able to actually look deeper into the changes or improvement that my patient had. And with the mini best, I'm actually able to see if there is any change in anticipatory, which wasn't. And actually, we had anticipatory, which is like things such as standing on one leg or standing on tiptoes. Actually, if we go back and you look at the slides, there was a slight improvement with the Otago, as expected, because Otago targets the strength of the lower limbs only. Then we have reactive balance, which is how quickly you react when you lose your balance. And that usually increases in the IMT. If you look back at the slides, you will see that that one component that increases. Sensory, which answer as well your question about people with specific impairments, because with the sensory one, you ask people to stay with their eyes closed, you ask them to step on inclined ramp, you ask them to step on foam surfaces. That actually doesn't change much on the IMT group. And then dynamic, though, which is the one where you have kind of gaits and things such as walking without turns, stepping over obstacle, is the one that improved the most. So I'll say potentially we can use others, and we are in future research, we're probably going to look as well at Tinetti and Berg as well, balance scales, although the mini best is the one that allows you to look into specific themes. So in my opinion, is definitely the one to go forward because allows you to do this kind of clustering of results, which is necessary because otherwise we will see improvement in balance, but we won't understand what elements of balance has improved. And as Pollock mentioned, 2000 is a multi-dimensional concept referring to a person's ability not to fall. And we need to actually look at the multi-dimensional concept that is in there, because otherwise it will be just a number going up.
Yeah, brilliant. I think I will leave it there.
Okay.
Everybody is saying thank you so much, and
Oh,
I'm particularly grateful. That was honestly fantastic.
oh,
Thank
cheers.
you very much for
I
your
appreciate
time.
it.
And I'm sure we'll be in contact, as I say, for round 2 in the
Oh,
near
okay.
future. So you've got many a teacup on your desk, as you said. So I hope you go and make
I mean,
yourself a nice warm cup of coffee.
I don't know if you can see it's 1, 2, 3. I promise it's tea, it's not coffee, but yeah, I have to clean my desk.
You're Italian. I'm surprised it's tea and
No,
not.
I don't. Well, I've been in the UK long enough to drink tea now, which is just not good, I guess.
Thank you so much, Francesco. And yeah, I hope you have a good day. Thank you very much.
Thank you very much,
Thank
Sabrina.
you, everyone, for
Bye.
attending. Bye. Bye-bye.